Welcome everyone to this, the penultimate board before the festive season and Christmas break. Things are obviously very, very challenging at the moment in healthcare across the UK, so we'll be covering the operational performance issues for us at the George Eliot today. We've had a busy morning already covering off freedom to speak up, patient safety, the work we're doing on our new EPR system. And an improvement story given all of the great work we're doing on same-day emergency care. So the board have already had a busy session, but delighted to see so many friends from the public and elsewhere with us today. So we'll get going. I don't believe we've got any apologies for absence. Any new declarations of interest? Please raise a digital hand if you've got any new things you need to declare. Okie dokie, I can't see any raised digital hands. The last set of minutes held on the 4th of October. We had a 3 boards meeting in November of the 3 different boards of the foundation group. But from the 4th of October public board meeting, any comments on those minutes? Please raise a digital hand. I can't see any digital hands raised, so I'll take those as accurate and therefore will sign them. Jonathan Collett, could I just ask you to put your microphone on mute for me, please? The action list arising on page 17 of the pack. A number of these have already been completed, but we'll run through them just quickly. The first was for Robin to liaise with his counterpart at UHCW regarding the ENT SLA. That was done. Thank you, Robin. Robin to review the content of the letter sent out from the ICB to ascertain if we had sent our apologies out to those patients and whether UHCW had done the same. Robin, just to confirm, we have apologised to all of those patients who had a delayed experience. Is that correct?
Yes, that's correct.
Okay, thank you, Robin. And then Robin to look at the different options and take those to the Trust Management Board. You've done that, Robin, and you briefed us on that earlier. Thank you. We can assure patients and their families that there is a plan in place to ensure that the appropriate levels of care are achieved going forward. Glenn, to brief the board on the ICB discussions pertaining to the Secretary of State for Health and Social Care's plan for patients via his Chief Executive in due course. Glenn, did you want to do that as part of your Chief Executive report or now?
Yes, I'll do it as part of my report. That's okay, Chair.
Of course. And then Catherine and Robin to bring back a CAS card to board to provide a clearer picture on those factors affecting the 62-day performance. We're going to cover that on the integrated performance report. Thank you, Robin and Catherine. Systems finances to be included in the integrated performance report. Thank you, Hack. That's complete and will be ongoing. Sarah to provide guidance on the new code of governance for NHS providers with the audit committee. That's done. Importantly, we will now be producing a provider license as part of the assurance to members of the public. Then just keeping things moving, just bear with me. And then Jenny to provide the board with an update once the sustainability service has been undertaken, the findings are available. Jenny, we're coming back to that next year, but I'm always particularly conscious of Councillor Caldercott's suggestion about how we can use green energy more on site. So if you can make sure you keep us updated before April, that would be good. Then Hack to ensure discussions held at board workshop regarding productivity are incorporated into the dashboard. That's been done. Looking forward to talking about that, Hack. Kirsty, as head of estates, to arrange photographs of the newly refurbished League of Friends cafe to be presented. That was done. We were delighted, I think, David, that yourself and Marcus opened up the new League of Friends cafeteria, and thank you to all the support of League of Friends over the years on that. Then Natalie to explore making the quality account more relevant, similar to the way the annual operating narrative was produced, and present that at a future workshop. Got that for next March. Thank you, Natalie. Natalie to bring a visual back to the board onto how the electronic ward dashboard looks. That's on the agenda. Looking forward to that. And Natalie, you're on a roll to provide a more detailed analysis in regard to birth rate demographics in response to Councillor Condipot's question. We'll come back to that in March, but we will be picking up on the Embrace audit that was done and how it relates to us a bit later. Are there any action points arising that I've missed? Please raise a digital hand. Okay, so Natalie, over to you on the update on the nursing quality electronic dashboard, please.
Thank you, Chair. The report is included within, it's a very brief update, and I know that the three chief nurses from ourselves, Swift and Y, also presented at the Strategic Improvement Board last week with regards to assessment, accreditation and the progress on the dashboard. So to get a fully integrated electronic dashboard is proving to be rather complex, and we are still committed and progressing on that. So in the interim, between the three of us, but also individually as organisations, we've undertaken a review of what's currently available on what are traditionally called nurse sensitive indicators, and triangulation of those sensitive indicators with actual outcomes, the observational 15 steps methodology, complaints, patient experience, but linking it all to our safer staffing and our gaps or vacancies and fill rate. So right at the end, Appendix 1, I've given a very brief overview of what it will look like that we will be able to receive on a monthly basis within nursing. I purposefully at the moment have not included maternity because we know that maternity have their own dashboards through the LMNS, and also there's a heat map at the moment going through region to have a look at, and from the Kirkup report regarding what indicators and measures we need to look at. So purposefully have not included maternity at this moment in time. So that just gives an oversight of what we're going to look at, how we're going to put it together, and the process will be that through the nursing forums, through the heads of nursing, we'll be able to drill down into areas where we recognise any trends or that triangulation as I've stated. So that's the update for the moment, Chair, and then as soon as we do get progress on the electronic versions, we'll be able to bring that forward to the board.
Okay, that's great. Thank you, Natalie. Any questions to Natalie? Simone?
Thanks. Thanks, Natalie. I can understand why it's probably more complex in practice than it might seem in theory. You've answered the question I had about midwifery. My question is also about allied health professionals. You know, do we have similar measures for allied health professionals, and if so, where? And if not, is that something that we should be thinking about?
There isn't anything nationally that would be just pertinent to allied health professionals. However, when this dashboard looks at the wards, those where there's more specific allied health professional involvement, thinking like Felix Holt, then absolutely those measures will pertain to that area as well. And when I'm talking about the nursing forums, at the Senior Nursing, Maternity and AHP forum that I hold every month, we have our allied health professionals alongside us with that. So when we're talking about improvement measures, if it might be falls, for example, then that absolutely will include OT, physiotherapy, pharmacy, because we know that those elements can influence falls and any deterioration and deconditioning for our patients. So although it's not specific, Simone, they absolutely are involved and a key point to our improvement.
Thank you, Natalie. Thank you.
Very clear answer. Julie?
Thanks very much, Natalie. And we did have a really good discussion at Foundation Subgroup last week around the importance of the dashboard in showcasing best practice, good practice. I've just got a couple of questions. One was around when this will be introduced. I'm not 100% clear about the timing, not the electronic one, but actually in terms of the use of the dashboard. And the other one was around using this for yourselves, but also for board in terms of getting assurance around patient experience. So for me, it was not only about friends and family that's included within those that data set, but also how you bring them all together in a narrative. So it's about friends and family, and then looking at that in context of care hours and observations, how that will all be brought together to get a view of patient experience.
Thank you, Julie. It's a great question, and for patient experience, that can often be slightly more tricky to triangulate. However, what I would say is that what we'd be doing is bringing that back to the patient experience and carers group that we have each month, and being able to really look at, and particularly thinking as well about any harm reviews. We triangulate the staffing levels with regards to if there's been falls in a certain area, or if there's been pressure, skin integrity damage, etc. What I'd eventually like to do is expand out that patient experience section to not just concentrate on the friends and family test, but how we can progress and do that and have that involvement, I think, will be a work in progress. And as for when we can see this coming into action, I think in the summary I've said that the aim will be that in Q4 all of the teams will be used to this, and we'll be taking it through the forums. And not only will it be through the senior nursing forum, but this will be utilised at ward level. So the expectation will be, particularly when they're having the care excellence assessment and accreditation that we talked about last Tuesday, each ward member will be able to talk about what's showing on their dashboard, which areas they're concentrating on, and they know that they want to see that improvement. So that's how I see it being used in its totality.
Thanks, Natalie. I think on the issue of patient experience, just building on Julie's comments, this seems to me to be an ideal area to work with partners in the ICS, because clearly patients regard the healthcare system as a continuum rather than a series of individual providers. And there's some really interesting research that's being done, I know, in the Integrated Care Partnership. So I'll try and link you up with some of the work there. But if the more we can try and coordinate with systems partners, the patient experience across the whole of the system, I think that the more complete our understanding of how patients are feeling will be. Colleagues, happy to move on? Okay, thank you, Natalie. And as Julie said, we had a really interesting presentation last week of the Foundation Group Subcommittee on ward accreditation or care excellence going forwards. That segues quite nicely into the minutes of the Foundation Group 3 board meeting held on the 2nd of November. Now, for members of the public, what we are doing going forwards is every 3 months we are going to have the 3 different parts of the Foundation Group, Swift, George Eliot and Wye Valley, come together in a public board meeting. The purpose of those is to provide more comparative analysis of how each part of the Foundation Group is doing, not just against a general benchmark of comparatives in the NHS, but also from one another. The purpose of the Foundation Group is to identify and share best practice at pace. And so members of the public who join us at the George Eliot board every month, we would be delighted to have you at one of those 3 board meetings going forwards. So we have in the pack the last set of minutes from the meeting held on the 2nd of November. Any questions on those minutes in terms of accuracy? Please raise the digital hand. Okay, I'll duly sign those on behalf of the George Eliot board then. And then I think the only action point arising, which is on page 36 of our digital pack, was a request from a Swift governor regarding the use of acronyms, which is always a good challenge for all of us and all of our boards, and so we noted that request. Colleagues, happy to move on to Glenn's update. So Glenn, over to you, and if you could pick up that earlier point, that would be super. Glenn.
Yeah, thank you, Chairman. So, yeah, that point was about the plan for patients, which was actually published by the previous Secretary of State for Health, Theresa Kofi, but appears to have been adopted by the current Secretary of State for Health, Steve Barclay. And what we were talking about last time was what has been the ICS reaction to that. I include within these papers an update on the creation of an integrated care strategy from our ICS. A lot of the work so far has been establishing governance across the system. So that update is there to position where we are, but I'll also reference some next steps in a moment. Also, interestingly, there has been an announcement that there is going to be a quick review by a previous Secretary of State for Health, Patricia Hewitt, of the way that ICSs work, not to change policy, but to ensure that they concentrate on appropriate things relevant to their new role. So my report then talks about the autumn statement, which was published by another previous Secretary of State for Health, Jeremy Hunt. There's a lot of them back on there. So Jeremy Hunt set this out a few weeks ago in the context of a really challenging fiscal situation for the country, but gave an announcement that there would be additional funding to the NHS of £3.3 billion in each of the next 2 years. Now, that falls short of the £7 billion that the NHS Chief Finance Officer had suggested was necessary. Although the national team are now saying the lower settlement is sufficient. Now, why is it they're saying that? They're saying that because alongside that wider fiscal package, there has been a review of the inflation assumptions for the coming year, and those have been so there's a reduction in the expected level of inflation, which obviously gives more real terms resource to the NHS. Notwithstanding that, it will be challenging, and what you can see there is that this settlement falls short of the average settlement that the NHS has had throughout its life. The NHS obviously not only faces inflation, but it also faces growth in demand for all sorts of reasons. What was encouraging in the annual funding statement was a higher than expected allocation to social care, which will be welcome because you can't look at health funding without looking at social care funding. And then it also signalled the fact that we will get our NHS detailed planning guidance by just before Christmas is what we've been promised. The 19th has been suggested of this month. It often comes out Christmas Eve, but we will look forward to that. That will give us a better picture of what the national assumptions are, what the priorities are, what we can expect to see from some of the conversations that went on alongside the NHS Providers Conference, which is also in my report, is a smaller number of higher priority focused targets for the NHS, and those are likely to be set out in the planning guidance. My report then goes on to talk about the ENT service, which we talked about last month. If I could just correct one point in my report, it refers to 409.5 sessions a week. It should say a year. The context of this, though, was a challenge for our colleagues in UHCW to deliver the service to us due to recruitment issues in their ENT service. So what we've put in place now is a local service with a consultant-led provision, supported by colleagues in South Warwickshire as part of their ENT team, but delivering a local service to Warwickshire North residents to the level originally set out in our SLA for a slightly lower cost, which is great. So that's a win-win for the system, because that frees up resources for UHCW to tackle some of the challenges around cancer waiting times, but ensures that we will have a much better local service. And I reiterate my apologies to any patients who waited longer than they should have for treatment at George Eliot. With this capacity in place, we will be in a very strong position to ensure that we deliver against all future milestones of the National Elective Recovery Plan. I then referred to the NHS Providers Conference. It was lovely to be involved in talking about our improvement approach as a group as part of that conference, and very much our modus operandi of sharing best practice at pace, but also creating a culture where we're encouraging people to improve and to try new things and innovate. And we saw some fine examples of that this morning again in workshop when we looked at our same-day emergency care pathways. I won't go through all the elements of that, but they're all there, hopefully provided by NHS providers. I then refer to a national provider collaborative innovators programme, and we've helped to shape this. I've been involved with those discussions, but also through the association of groups that we're a member of also. So that includes groups from all over the country who have got models like ours, some slightly different to ours. And what we're trying to encourage is the concept of more provider collaboratives, which exists for improving the quality of services, the resilience of services, in the way that we've certainly benefited through being involved in our group. I mentioned here that we are considering whether the group should put forward a proposal. We are going to put forward a proposal, met the managing directors and chief strategy officers. Those submissions are required by the end of this week. What we will be suggesting there is, as a more mature group, there's an opportunity to test what provider collaboratives could do, but also to be involved with the national shaping of the framework through which provider collaboratives are given more autonomy, which we certainly welcome. Then I refer back to the consultation on the Code of Governance for NHS Provider Trust. I talked about this in July. That's now come through and will be implemented in the way that we discussed it. So I won't go through all of that. The implications for George Eliot are that we will be assuring ourselves on an annual basis that we're compliant with that license, and there's a role here for audit committee, which is set out there. And then we go through some updates from parts of the organisation, starting with medicine, and great to see here, actually, reference to my earlier point, that there are no patients waiting longer than 52 weeks across our medical specialties, which is significantly ahead of the national milestone, which is actually for March 2024 to be at that position. So well done to that team. Also refer to SDEC, same-day emergency care, which we talked about earlier. Positive consultant recruitment. There's then an update from the cardiorespiratory unit and the community diagnostic centre. Great to see them moving into that lovely facility, and that's a real benefit to local patients and more capacity there to be built in the future. And then a long list this month of the visits from executives, and non-executives will be joining those visits, but that column isn't filled in. Happy to take questions, Chair.
Thank you very much, Glenn. Questions or perspectives to Glenn, please raise a digital hand. What's worrying you most at the moment, Glenn?
So we are, it's starting to get cold out there. It never feels like we left winter last year, actually, but winter is with us now. And this winter has many other features to it, including the prospect of industrial action. What I didn't include in my report, because it's evolved over the last week or so, is that whilst there won't be any direct industrial action at George Eliot, there will be industrial action around us, both within the NHS and other public services. So we're bound to be impacted by that. And we're already seeing high levels of demand. You will have seen over the weekend the respiratory illness for children. There's just anything that could be thrown at us will be thrown at us this winter. I think we're very well prepared, but it will be tough. So I'll worry about that a little bit over the next few weeks.
Thank you, Glenn. Just so members of the public know, I worry about ensuring that we with our colleagues in social care, are able to discharge as many patients as possible to free up capacity in the trust. We'll move on then, if there are no questions or perspectives, to Glenn. Thanks for your hard work, Glenn, both at George Eliot and more generally. To the Estates Quarter 2 update, Robin and Kirsty, over to you.
I couldn't get off mute there. Afternoon, everybody. I'm going to take it that the paper's read and just draw your attention to some of the main features really of the report. So we've been frantically busy since the last quarter, moving into our new accommodation. So the old boiler house has been refurbished and we successfully moved in 2 weeks ago. The old estates building literally fell down, I think, within a day after we moved out, ready for the phase 2 of CDC. So that's all progressing really, really well. The CDC wall phase 2 is well underway for the planning stage. We've had some really good engagement meetings with the services that are going in there, and with contractors as well for MR and CT providers. So that's really positive on that front. We've also been doing a lot of work in the maternity building, one to form a compliant second theatre, and also to complete some of the works regarding the infrastructure, particularly the hot and cold domestic water services in there. We still haven't heard anything about the new hospital programme. I don't know whether we ever will, but we'll keep chasing. Space utilisation as well is a big push for us at the moment, particularly the new building here in the States gives us some opportunities, and trying to show around prospective neighbours into this area. And we've also got some works in the maternity building again that we're doing to free up some space. And I think the last thing to note, I put some pictures in the report of the League of Friends Cafe. So that opened officially last week. The volunteers there are doing a fab job, and I think you'll agree it does look a lot better. Feedback's been very positive as well from there. So well done to the League of Friends for doing that. So does anyone have any questions?
No, thank you, Kirsty. And just to reiterate to Natalie and everyone else in the League of Friends, enormous thanks for, it's taken us a lot longer because of COVID to get that Friends Cafe work done, but I think the photographs sort of illustrate, as well as I know the reality, just how worthwhile those changes are, and we greatly appreciate the support of League of Friends. Any questions to Kirsty or Robin for that matter on the estates update? Julie?
Sorry, Chair, I couldn't get off mute. Thanks, Kirsty, and thanks, Robin. And it's a good update. And those of us that are closer to it will fully appreciate the process by which these schemes get approved and the benefits that they will bring. I guess for me, there's something about in this report, it's not always clear. And I know you can't put all of the benefits, but it's just for public's benefit that we're very clear that these all bring benefits, either safety or patient experience. And if there was some way of actually bringing that out in the update, I think that would be really good.
No problem.
Julie, thank you. Catherine?
Yeah, I just wanted to say how positive that report is, to see all of the areas of development that are going on around the organisation at the moment, which, although maybe not highlighted clearly, are definitely to bring improvement for patients that we serve. So I just want to thank Kirsty and the team for all the hard work, because it's really exciting to see so much going on.
Thank you, Catherine. Lorraine?
Thank you. I'd just like to say a huge thank you to Kirsty and her team for all the hard work they're putting into maternity to help us improve our theatres and the infrastructure. It was just around, obviously, we're very jealous now because we've seen League of Friends' lovely cafe opened in the main building, and staff are obviously asking, is there a timeline for when we can get the League of Friends cafe in maternity open, please?
Yeah, they were using it for storage while they were refurbishing the main cafe. So now that that's empty, we've said that we'll give it a little bit of a spruce up, and then we'll look to open it in the new year.
Thank you, Kirsty.
Thank you.
is keeping things going for time. And Natalie?
It was probably Lorraine just said exactly the same as I was going to do, to thank Kirsty and her team for being so proactive and reactive when we needed works doing within maternity. And definitely the staff and the women will really welcome the cafe opening in the new year. It's something that they've been talking about. So for us to be able to say to them it's coming will really cheer up the spirits in these cold times.
Okay, great. Thank you, Natalie. And finally, Robin, then we'll move on.
Yeah, thanks, Russell. Just to underline Julie's point, really, there's so much of that's in that paper that is all about how we deliver patient care and the benefits to the patient care that we provide. And two of the points that Kirsty didn't cover but are in the paper are around the HSDU development of our sterile services unit, that a fourth washer put in there that helps us to turn around our theatre kit in a more timely manner, and also the works that are scheduled for February on our day procedures unit theatre ventilation system as well, both of which help us to continue and maintain the elective throughput for patients to continue to get their treatment through what Glenn's already described is likely to be a very challenging period for us going forward. So I think that's some really good points to emphasise. Thank
you, Robin. Okay, Tim, Kirsty, take care. If I don't see you before Christmas, have a wonderful Christmas. Thank you. So we'll move on then to the Warwickshire North Place Delivery Group Progress Report with Jenny and Salma. So I'm not sure who's going to lead, whether it's you, Jenny, or Salma, but got a few minutes for you, so over to you.
Thank you very much. So I think I'm going to lead us. Salma is on the call, but I think she's having a few internet difficulties, but she will. She's definitely on the call and listening. So I'll take the paper as read, but there are a couple of things just to draw your attention to that have been specific developments this time, particularly the focus on the long-term conditions work stream, which previously we've reported has been one of the work streams that had been paused and that we needed to have some discussions with our ICB colleagues in terms of capacity to take forward. And that is in progress and is developing. So we're pleased to note that we've made some progress in that arena for that work stream. Just moving down the report, a couple of other things that I wanted to particularly outline to you is the fact that we have picked up under our community capacity piece of work the anticipatory care initiative, which again is a system-wide initiative but has a focus at place, and the focus there was going to be around frailty and a particular sub-cohort within frailty. So we are making progress on that programme as a place, so that's something to note and to pick up. We previously noted that in our mental health work stream that there had been concerns raised by our primary care colleagues in relation to the additional roles, particularly around the mental health roles. And I'm pleased to say that we've sorted that out and secured the required roles that were originally negotiated and were part of the plan. So that is moving forward and is due to some conversations that have had at play. So that's really positive. Good progress in relation to the non-specific cancer pathways, which are indicated on the report, continues to have more referrals going through there. So we're pleased to see that continuing to develop. Finally, there are a number of things, quite a lot of things that are detailed within the primary care update, and just draw attention to a range of different things that are going on through primary care networks, particularly around the use of a number of apps, etc., which support anticipatory care. I think I will, and just to note as well that we have managed to get 2 lots of funding in through some links to our volunteering programme and also through a CVD programme focusing in relation to health inequalities, which we're running on behalf of the system, specifically in Warwickshire North, but we'll have learning for other places. Those are the kind of key points to draw out of the update this time.
Thank you, Jenny. Salma, I'm not sure if you're able to hear me or wanted to add anything.
Thanks, Russell. It was just to note that in terms of long-term conditions, with the progress that we're making, we will be having a set of focused discussions into the next place executive, noting that we've had some internal discussions at Trust Management Board, so some things to build across and connect together there.
Okay, super, thank you. Questions and perspectives, Glenn?
Apologies for the fire alarm in the background. I may have to leave the building in a moment, but I'm going to ask a question nonetheless. Jenny, I know there's some work going on at the moment to produce a levelling up report for Warwickshire North. What's the timeline for that?
Okay, so actually that's quite timely. So there was a meeting this week to just finalise some of the inputs from our broader colleagues, particularly around our workforce piece. And so we're anticipating it quite soon. I'll just ask Salma if she's got a specific date on it, but I know it's in progress and the final meetings were concluded this week.
Yeah, so we've confirmed with Purpose Coalition that they've received all of our information now. We've responded to all the queries. We are expecting that the report will be available to us in the next 2 weeks.
Okay,
Date yet confirmed.
And keep us brief, Glenn, if you have to evacuate on a shoot out of your office. And Julie?
Thanks, Jenny, and thanks for another update. We've been receiving these for quite a while now and shows the progress in the programmes. I'm just interested to understand how this is being reported through ICB and the ICP through the partnership as well. How's that actually working?
Yeah, so that's an interesting question because we do have colleagues from the ICB that are invited to attend the place meetings, and they do attend and they do receive the papers. In terms of a formal reporting up through the ICB structure in terms of this report, it doesn't go into an upward report anywhere at the moment. One of the questions that we've raised, and I've raised it in a couple of forums actually this week, is exactly how the governance is coming together and how we actually feed through. So at the moment, we are somewhat reliant on the ICB colleagues that joined the meeting to be feeding back through, although I have had a specific set of meetings with Laura Nelson in her new role as the integration lead for the ICB, and I've also met with Angela as well in her role. So we are trying to make those connections in terms of links, but in terms of formal reporting, this report doesn't go anywhere directly into an ICB governance structure as it stands.
We need to sort that one out, I think, Jenny. David, because we're running over a bit now, but David, and then we'll move on.
Yeah, sorry, Russ, I was just going to say that exactly what you've just said. We do need to sort that out. Danielle is going to come and join us at our place executive meeting in January, and we're busy working out what the agenda might look like for those conversations, and I think that's one of the things we could usefully talk about there.
No, great, super. Thank you, David. Thank you, Jenny. Thank you, Julie. And so we'll move on now then to the planning approach to deliver the annual operational plan for next fiscal year. Hack and Jenny, over to you.
Yes, so I think I'm picking this up, and we've also got Mark Roscoe who's joined us for this item as head of planning as well. He's been integral to the report. So again, I'll take the report as read, but a couple of points that are important to note. So this paper sets out the planning approach for the forthcoming year. As Glenn had already indicated, we haven't as yet had the planning guidance released, and it does usually come on Christmas Eve, as it was indicated. But obviously, clearly, we are already setting in motion the requirements in order to be ready for that cycle of planning. So what the board basically what the paper sets out basically is the approach that we're taking this year, which is built on two previous very successful planning grounds for us, and has built in the assumptions that we worked on from last time, and we are really just moving forward on that basis. So basically the key messages are the guidance isn't yet out. We expect it towards the end of December. We've made a number of assumptions that are building on previous planning grounds, and those are set out in the paper. The planning approach that we're taking forward does build in clinical and operational engagement through the development of our service development plans, and seeks to triangulate those ambitions with our activity and workforce and financial planning in line with the assumptions that we're making relating to the guidance requirements. We have established a planning and coordination group, which basically gives the oversight and drives that planning process forward, and that's meeting on a weekly basis, and that has good engagement again from clinical and operational colleagues, and also the corporate services that are integral to this. So, for example, finance, quality, and our workforce colleagues for the activity planning and workforce planning. We will, we anticipate, need a delegate agreement to have a delegated sign-off, which is what we put into the paper as a request to be endorsed by the board today, because there won't be another board meeting within the timeframes for the submissions. We obviously will then bring back the submission for ratification. We have made a number of assumptions in terms of the financial framework that we'll be working to that will inform the submissions, and those are set out in the paper, but notably the requirements around productivity, efficiency, and what will happen around any ERF income and CPIP cost improvement requirements. We know there are a number of risks in relation to taking forward our activity planning going forward, particularly in relation to vacancies, key roles, staff sickness, etc. But obviously that will be part of the assumptions that we'll be setting. That was the key pieces of information I wanted to pull out from the paper, but as I say, Hack, Mark and myself can pick up any questions if there are any points of specific questions that you wanted us to cover off in addition to what I've said.
Thanks, Jenny. Thanks, Mark, for your hard work behind the scenes. Thanks, Hack. So any questions? We've got a few things we need to approve on this, but just questions or perspectives, Catherine?
Yes, Jenny, I know you and Mark will be doing it anyway, but can we make sure that we revisit our clinical strategy as we're developing the Directorate service development plans? Because I know you and Salma did a useful stock take of where we'd got with that. And it was great to see how that's you can see that coming alive in the estates plan that we've talked about. So another opportunity to make sure we continue to make that a living document.
Point well made. Thanks, Catherine. Glenn, did you want to come in on that?
No, it's on a separate point, so I'm happy to wait in turn.
Okay, fine. Simone?
Thank you. Thanks, Jenny. Very comprehensive and understandable paper. It makes reference to a set of leadership behaviour commitments. Is that the first time we've had something like that? And how is that going to work in practice?
Yeah, okay, so I'll pick that up, and apologies, my dog might be barking in the background. So in terms of those particular leadership behaviours, they are part of the national operating framework that is set nationally, and that's what's referred to in the paper, but they align really well with our values that we've endorsed throughout the culture of the organisation going forward, and do a good read across.
So how is it going to work in practice? Is this for people holding each other to account? What's it going to do?
Sorry, the operating framework.
These behaviours being in the framework, what difference is that going to make? What's it for?
So there is a national operating framework that's been published by NHS England, and that's part of the national framework, and the behaviours are part of the expected standards of leaders within the NHS. So it's part of a national framework. They do correlate, as I've said, to our values and behaviours that we've already incorporated into the way we work as part of our trust.
Okay, thank you.
Sarah?
Thanks, Jenny. Thanks for this. It was just really a comment on in the executive summary around the line about health inequalities, where it says that there's a plan and it talks about an improvement in outcomes, or reduction in health inequality by improvement of outcomes. And I just wonder, as we go forwards, just really and ask that we give some clarity to that. I think that the words that go before it look like they can reduce health inequality issues related to access and experience, but I'm just not clear how that would necessarily improve outcomes. and so it's just going forwards a bit of yeah, it'd be interesting as you have more of a framework how that develops and what we actually mean by an improvement in outcomes. And I wonder, as we again move forwards, this links to your previous paper, when actually some of the improvements in health outcomes may well be related to us working together in partnership across Warwickshire North with a wider set of partners on some of the wider determinants of health, but definitely a reduction in outcome inequality of access and experience I can see coming through in what you've written, and I welcome that, so thank you.
Yeah, I think the general point which I support is we need to make sure this is not just motherhood type intent, but actually real intent with real action to achieve the aims that we want. And finally, Glenn, because we are running late now. Glenn?
A quick question for Hack on the draft financial plan. Conscious that this will be, we'll have to reflect when we see the planning guidance, but we refer to a 4% CPIP target with 20% slippage. So does that mean it's a 3.2% target, Hack?
No, it's the other way around. It's 4%
plus
the 20%. Yeah, so it's about 5%. Yeah. So it's with the aim of delivering 4%, we need to plan at 5%. So we're saying there's always some things that won't deliver. So for planning purposes, we'll plan at 5%.
Got you.
Glad you said that, Hack. Okay, so on page 77, we've got the things we're being asked to approve, which I'm just going to quickly rattle through. So if you're not happy to agree the approach to planning for 23-24 as laid out in the paper, please raise a digital hand. Duly approved. If you're not happy to approve that the directorate budgets are based on the indicative assumptions laid out in the paper, please raise a digital hand. Duly approved. If you're not happy to agree to include a planning contingency of 20% as Hack has just outlined on CPIP, please raise a digital hand. Okay, if you're not happy to note the cost pressures which could adversely affect CPIP and lead to an increase in that, please raise a digital hand. Duly noted. If you're not happy to agree the approach to activity planning for submission through delegated authority to me, Jenny, and Hack, and Robin, and David, please raise a digital hand. If you're not happy to approve the material changes required to the draft plan submission, which are not able to take through board approval given the timing of things, that again there's that same delegated authority, please raise a digital hand. And if you're not happy to approve that the management board can recommend approval of draft budgets in advance of things getting to the main board, please raise a digital hand. All of that's duly approved. Thank you, Mark. Thank you, Jenny. Thank you, Hack. And hopefully things do arrive on the 19th of December rather than at 4 p.m. on the 24th. I need colleagues now to pick up the pace a little bit as we're running 10 minutes late. So, Natalie, the report on safe nursing and midwifery staffing, please.
Thank you, Chair. There's a lot of detail in the report, and we recognise that nationally workforce, particularly nursing and midwifery, is highlighted everywhere. But the areas from the report that I'd like to bring to the board's attention are that we continue to focus on our nursing vacancy rate as this remains high, and it's higher than we desire. There are programmes that are ongoing to address this, including collaborative working with UHCW and with SWIFT. And the programme for international nurse recruits has started. We've had 8 join us who were already in the UK and 10 from India in December. We have another 20 joining us in January, and we're working very hard with the onboarding and the welcome of these staff and integrating them into our care delivery. There's multiple staff moves that take place on a daily basis to ensure patient safety and care delivery, and in future reports I am suggesting that we add these to the report so that you can see that on a twice daily basis huddles are conducted by the senior nursing team to ensure the safety, and any mitigation that's needed across the organisation does happen, is escalated to ensure that there is a safety and outcome towards care that's delivered, and that we triangulate these with any incidents that do happen to take place. In the report, you'll note that there were 20 red flag incidents raised in the general side of the organisation and 8 within maternity, none of which, I'm glad to say, resulted in any moderate or above harm. There were 3 episodes of low level harm. Each one of these was looked at, and again, it did not affect the care or the length of stay for these patients. The board will note that there was a slight reduction in the midwife to birth ratio in October at 1 to 32, I think it was 30, but I'm glad to say that this has resolved in November at 1 to 28, and the reason for it was an increased number of births that we saw in October, an increased sickness in our midwifery staff, and the vacancies that we currently have. Although, again, you'll note in the report that we're in a very lucky position to hopefully by December, January, to be virtually fully staffed within our midwifery service. And on a positive, going back to the recruitment point, it's just to note that we have a trust-wide healthcare support worker recruitment day on the 12th of December, and we already know that we've got 20 plus people attending that event, and we have a registered nurse recruitment event happening in mid-January. So that probably as succinct as I can get for you, Chair, and happy to take any questions on the report.
No, very clear. Thank you, Natalie. And the midwifery staffing ratios in our midwifery recruitment is fantastic. A 1 to 28 ratio is super, very similar to what we have at Swift, but indicates you know, the real investment we've made there. Any questions or perspectives to Natalie? Sufficiently clear, Natalie, that we don't have any questions. So we'll move on then to the report on acute independency reviews. Back over to you.
Thank you. And the board will note that this is on a biannual basis. I bring a report to the board to review and look at the requirements of our establishment to ensure that we have safe staffing across the organisation. And this is part of the National Quality Board recommendation through NICE and NHSE. In the report, it demonstrates the triangulated review that we've undertaken. We use a nationally recognised acuity tool, which is the Safer Nursing Care tool, use professional judgment together with myself, the deputy and the heads of nursing, and also look at some of the nurse sensitive outcome measures. And the table at the back of the report gives you a demonstration of all of those prospects that we look at. The paper describes the methodology and an analysis of the data, as I said, in Appendix 1, but areas that are not included are described, and the next steps for them have been included within the report, such as for DPU maternities, formal birth rate plus is due in 2023, which we will be undertaking, and looking at other areas such as SDEC, etc. The paper highlights 2 wards which the senior nursing team are recommending for an increase in the budgeted establishment. This is from both professional judgment but also from the Safer Nursing Care tool, and they are Elizabeth Ward, which is our respiratory ward, and Bob Jakin, which predominantly is our elderly care dementia ward. The medical directorate have been encouraged to discuss these at their budget setting and to take them through that business case review group. 2 further recommendations have been mapped out within the report, and these are to do with a gradual and phased approach to increasing the clinical supervisory time that our Band 7 nurses, ward managers have to enable that quality of care, but also that workforce development, obviously stepping into clinical practice and supervisory work with the teams. And that, as I mentioned, would be on a phased approach, because we do recognise, obviously, the financial limitations that we have got over the next coming years. And then the second part is to be looking at the gradual implementation of a nurse in charge, which is not at the moment in the establishment reviews, but we know from a outcome, quality, safe care, but also for operational flow, admission and discharge, it's a crucial role to be able to support this in the wards going forward. But we will do that in a planned way when we reach such a level that our vacancies are lower than they currently are. Happy to take any questions.
Thank you, Natalie. So just before I open up to any other questions, as chair of our Quality Assurance Committee, are you feeling assured by what you hear about the outputs of that report and review?
Yes, I am, and the way that we have looked at this on an ongoing basis, culminating in the reports, doesn't really leave any surprises. So thank you, Natalie, for presenting that to us.
Okay, thank you, Sarah. Any questions or perspectives to Natalie? Julie?
I just wanted to pick up on that, please, Chair, just in terms of linking this report to the previous one about safer staffing, which obviously Sarah's alluding to, but also the operating planning. I think I heard then that you said it was being built into the budgeting process, so there was that bottom-up process. But I just wondered as well, the report it quite openly talks about where there are establishments where are under, but there are those that are over. And I just wanted to relate that to the previous safer staffing report as well. Is I'm not quite clear. It left it a little bit hanging about those that are over. So can you just give us a little bit more assurance around that?
Yeah, predominantly the two areas that are over on, or there's against the safer nursing care tool, not necessarily against the professional judgment that they are over, are with regards to Captain Tom, and the time that the safer nursing care tool was undertaken was July. So not necessarily having our full elective complement, and the safer nursing care tool looks at the acuity and dependency of the patients at the time compared to the staffing levels. The other thing about Captain Tom is we're at the moment undertaking a trial of enhanced care, which means you increase your staffing and the skill mix of your staffing, but actually it reduces the length of stay for the patients. So that is being undertaken, but the safer nursing care tool does not pick up on anything like that. The other thing with the safer nursing care tool is it looks at direct patient care as described within the report. So therefore, if areas do have a nurse in charge, they count that as actually in your establishment as being over compared to what you need for direct care. And it isn't only direct care that takes effect on a ward, as we all know. The running of it, the operational management, etc., environment, it doesn't take that into account. That's why you triangulate it with professional judgment. So in those opinions, what we did look at is whether we felt that anywhere was excessively over, and therefore would we undertake that review and potential move of establishment in the first instance rather than adding to or requesting adding to the budget. We need particularly our surgical area to settle down and have that sustained activity. So our next review will be in January, when hopefully we'll be a lot more on an even par and we can see what's happening for real.
Very clear answer. Thank you, Natalie. And finally, Simone, then we'll move on.
It's obviously a very thorough process that you go through, Natalie, quite rightly focused on the large majority of our workforce. Hack and I did some walkabouts last week to non-clinical areas, and clearly there are issues of staffing in those areas which impacts on morale and ultimately on patient safety and care. And I just wonder whether at a future meeting we could have some assurance about the same rigour of process that goes into looking at staffing in our non-clinical areas as goes into what you're doing about nursing and midwifery.
Can we take that away, please, David? I think that's a good challenge, and maybe discuss at TNB and then come back in due course with a suggestion. But thank you for that, Simon. Okay, Natalie, great to have you on board. I know it's been a few months now, but it's really great the impact and the way you've picked up the mantle as Director of Nursing. We'll move on then to the Maternity Assurance monthly update from Lorraine. Over to you, Lorraine.
Thank you, Chair, and I'll take the report as read. There was just a few areas I'd like to highlight, and I'd like to focus on the Embrace report mainly in this update. And as Natalie has covered quite a lot of the areas around vacancy and birth rates. So just to say, in October, we didn't have any stillbirths or neonatal deaths. We had one case referred to HSIB, but that was declined for investigation by the family as they were happy with the care provided. So and provided really fantastic feedback, which we've shared with the team. We are continuing to work on our Ockenden action plans and our CNST, looking at compliance, particularly focusing around our training and audit in those areas. The main thing that I'd like to bring to your attention is that in October 22, Embrace released their perinatal mortality surveillance report. This is a report that looks at any deaths from 22 weeks, and that could be fetal losses, stillbirths and neonatal deaths. And that was in the year of 2020, so the 1st of January to the 31st of December. As you can see in the report, we had 9 stillbirths in that year out of a total of 2,185 births. Those 9 stillbirths meant that our actual accrued data meant we were in 5% above the national average of stillbirths against the national and Midlands regional data. But as we did not have any neonatal deaths in that year, our extended perinatal rate meant we were in the category of 5%, should I say, below the national average. We know that that rate had gone down from 2019, but as we do an overlook and review all our cases and we look ahead, we know that in 2021 our cases for stillbirth will have gone up. We did a lot of in-depth review of those 9 cases to take away any learning, and we highlighted areas around documentation, but obviously we have implemented Badgernet in 2022, so our surveillance of data and record keeping has improved, and we can audit that on a monthly basis, and education and training was also identified as learning areas. We have to acknowledge that it's devastating for any family that has a stillbirth, but we do an in-depth review to look at that care. And of those 9 cases, although there was a devastating outcome for those families, we identified that there wouldn't been any changes in care that would have changed the outcome for those babies and those families. We are doing lots of work across the system. Obviously, we refer into a level 2 fetal med and a level 3 tertiary unit for neonates and our colleagues at UHCW. So we're working across the LMNS to look at ensuring that we are monitoring our stillbirth and neonatal death rates across the ICS, and the LMNS as well, to ensure that we are monitoring those. We're also working with the MVP to ensure that we're giving out assurance to our families around our stillbirth and neonatal rates across the system and the LMNS. Happy to take any questions on that report.
No, thank you very much, Lorraine. Questions and perspectives, Glenn?
Thanks, Lorraine. That's very assuring. The issue of the mortality data, very conscious with Embrace that we and our process that we're assuring ourselves and reviewing ourselves. I'm conscious that also we talk about the LMNS and work in the system. Is there more that could be done to add an independent review of stillbirths, particularly, to the process? And I just wonder whether that's something we could perhaps consider as a group, that we just ensure that we're checking each other for opportunities for improvement.
Absolutely, and I think as a foundation group, that was something that I'm, in my role, we'll be supporting that, to look inwards as well. And I think it was highlighted in the Kirkut report around: do we understand our data? Do we know what our themes and trends truly are, and are we reassured? So I think working across that with the Associate Director of Midwifery, we can look at that, as well as then feeding that into the LNS and regionally. We're working and supporting the regional teams with national dashboards, but actually I think we need to be assured that we're happy with our data and And I know that we've done a lot of work looking at our stillbirth rate within George Eliot, and a lot of forward look and real deep dive. So I can provide assurance here that we know our data, but we just need to make sure that we continue to monitor that.
Yeah, no, thanks, Lorraine. And Catherine?
No, I think that's a good point, Glenn. We do refer all of our cases to HSIB where they meet the criteria. So we've got that kind of assurance on that. With some of the stillbirths, all of these cases have what's called a PMRT. So those are all reviewed. But I think there is an opportunity there. That is marking your own homework to some extent. And there is an opportunity, I think, for us to work across the foundation group to do that in a more mixed up way, so that we're bringing in different views and opinions. But I would like to support what Lorraine's saying. Is this is an area that we have looked at in depth at QUAC, and we know what we're going to see in 2021, and we know the data for 2022 is actually much improved. So this is an area that we pay particular attention to because of the significant importance for families around getting this right.
No, well said, Catherine. And finally, Sarah Lastrick, and then we'll move on.
Apologies, couldn't get off mute there. No, just wanted to say to board that you'll see in their comment about the prompt training. I'd like to let board know that the Quality Assurance Committee have held this up over the last couple of meetings, and we have had a real trajectory and a plan from Lorraine about where we're going and how we want to see improvement regarding that. And just a comment again that we picked up at the Quality Committee, just to raise to board that whilst we do comment that we couldn't have altered the outcome of the stillbirths that are reported there, and we did make the comment that actually working regarding prevention, looking at maternal obesity, maternal smoking and other factors is really important, and whilst not related to the direct care later on in pregnancy, is something that we are conscious of and want to put work into. And again, Lorraine and her team supported that. Thank you.
Okay, super. Thank you, Lorraine. Thanks for your hard work. You're having a great impact. And but I do, as you've already heard me say in different form, the two most important things we do as a trust is to bring life safely into the world and to allow life to leave the world with dignity. So, it's very important we keep a high profile of this and continuously challenge ourselves, because as Catherine said, nothing is more devastating in life than losing a beloved baby for any family, and we want that to be absolutely minimised on our patch. We'll move on then. Thank you, Raj. Welcome. Good to have you with us this afternoon. Raj, what would you care to pick out of the mortality and learning from deaths Q2 report, please?
No, you got me, Russell, instead. So what I would like to pick out of the mortality report is our shimmy remains within the expected range at 109, but our HSMR is outside the expected range. We've done a lot of work looking into the causes behind that. And you'll see in this report that our palliative care coding rate is below the national average. We've been doing a lot of work with the teams around this, and our specialist palliative care team do review a number of cases that are not captured, probably around 15 per month. So we're just working on now coding those cases as well, which should hopefully improve our recording of the activity those teams undertake. The other thing I'd like to draw your attention to is the number of cases reviewed by the medical examiner, which in this quarter was 97% of all deaths, which is really great work. We have appointed a GP to join our team as a medical examiner because we are now running a pilot of reviewing community deaths. By April of next year, we will need to be reviewing all deaths, whether they occur in hospital or in the community, by the medical examiner service. but we're well on our way, and it's really encouraging to see different colleagues joining in the reviewing process, because I think that will bring fresh eyes, fresh perspectives on the reviews that are undertaken by that team.
Thank you, Catherine. Sorry to call you Raj. Any questions, Catherine, on the mortality report? And I assume I'm lucky enough to have you on the trust-wide incidents Q2 report as well, instead of Raj. So
you are, most certainly are. So I think this paper is largely factual. You can see, I think it provides quite a significant degree of assurance over the sustained level of incident reporting in the organisation. And you can see here that whilst the incident reporting over the past 5 years has gradually increased, the level of harm has stayed low, which is what we want to see. You will see our obligations under duty of candour are being met, and we are completing investigations in time with the guidance set out. Some of the learning, which is perhaps a bit too detailed for the public board, we discussed at QAC, and I just want to provide assurance that we discussed that through our directorate meetings, through the review of harm group, through our quality assurance committee, and through the serious incident group. So there's widespread forums for learning from incidents, as we discussed the importance of that through the introduction of PSIF, which we spent some time on this morning.
No, fantastic. Thank you, Catherine. Any questions or perspectives, Catherine, on the trust-wide incidents report? Okie dokie. Can you thank the team behind the scenes who produced that? So we're over to you, Gertie, for the health and wellbeing report, please.
Thank you, Chair. I'm mindful of time. I will just summarise very quickly. This report sets out quite a lot of detail in terms of the progress around health and wellbeing, and that it continues to be a central focus for us at the heart of supporting our colleagues. I'd refer colleagues in particular to the additional developments in health and wellbeing put in place from June to September, and that's seen in Appendix 3B. And just pick out a few key highlights in terms of the progress. Again, full details of this are available in Appendix 2, but I think it's fantastic to see that we're now fully aligned with the National Health and Wellbeing Framework. We have, as an organisation, achieved Thrive accreditation, which is hugely positive. We've seen an awful lot of development in terms of mental health support, such as the compassion circles, and a number of colleagues have undertaken psychological first aid training. Lots of financial wellbeing support, and we've heard a number of times today and in other forums the pressure our staff are feeling in terms of the economic crisis. So we've developed a really wide-ranging toolkit to support colleagues as much as possible. And alongside that, then there is the menopause toolkit and CAPE. So a really broad range of support. I can't comment on the excellent work the vaccination hub are undertaking and offering vaccines both to our staff and members of the public, and that's expanding out across a range of different vaccines, notably monkeypox, and we've now been approached to support refugees across Coventry and Warwickshire in terms of diphtheria and other vaccines. And again, we mentioned Appreciation Week was covered in Glenn's update, but just again to note, it was led by the health and wellbeing team and our comms colleagues, so fantastic work done from them. I'll leave it at that, Chair, but happy to take any questions.
Thank you, Gertie. Any questions or perspectives to Gertie? Okay, some really great work on health and wellbeing, so well done on that, and incredibly important at the moment. And I'd say to any members of staff and the frontline teams who might be watching this subsequent to today's meeting, if you need help, please reach out to your line manager or to HR. We're here to help you during these difficult times. So we'll move on then to the integrated performance report. David, what would you like to emphasise, please?
Thanks, Chairman. So we continue to develop the new integrated performance report, and you can see month on month the changes that are occurring there, seeking to be further consistent with our group partners in the way that we present data, and to make sure that there's a clear narrative in the report around areas of good and poor performance. In particular, this month we've included a new group version of the dashboard, which is starts on page 177 of 262 in the board pack. This is consistent with the same reports that will be provided at Swift and Wye Valley, and it means when we get into the 3 board meeting in due course, we'll be able to make direct comparisons between the 3 organisations, which of course helps with the objectives of the foundation group in terms of sharing best practice and learning from each other. In terms of specific areas of performance to focus upon, emergency pressures remains a key area of focus, as you would expect at this time of year, heading into probably the busiest and most difficult period of the year. Performance against the 4-hour standard is below 80% at around about 78% and remains there to date. Obviously, that's significantly below the 95% standard, but despite that, we're firmly placed in the top quartile of performance nationally. So relatively speaking, performing very well. But I do want to be clear that as an executive team, we are very clear that just because we're in that top quartile, there's still a country mile between us and where we would want to be. And so we continue to push for improvements and innovation to try and get into to get those numbers into better shape. Over our ambulance delays remain relatively small compared to other organisations. Where we do have delays over an hour, they're for very short periods over that hour, usually a few minutes. And we did have a 2.5-hour delay at one point last week, which was really an indication of the degree of pressure that we were experiencing in the system. But we aren't experiencing some of the very extensive delays that are seen in other bits of the region, with ambulance delays in excess, in some cases, of 10 or 12 hours. In terms of improvements, we continue to focus particularly on trying to deal with some of our wicked discharge issues and to make sure that we're able to discharge patients in a timely way from hospital. That involves close scrutiny of work within the hospital and also clear work programmes with partners outside of the hospital to try and smooth things along. And we had an update this morning at a board workshop about the progress that we've made with virtual wards, increasing the number of the amount of capacity that we've got to support people in their own homes using technology and teams based in the community to keep people at home and to allow them to go home as soon as they're able. And of course, we continue to push public health messages around access to healthcare when people need to access urgent and emergency care through the 111 system and various other routes. In terms of elective performance, our RTT performance is around about 70%. We have no 104-week patients, and we have no patients waiting longer than 78 weeks for their treatment. We have a relatively small number of patients now at greater than 52 weeks. That number stands at 66. It's quite a strong position, as Glenn's referred to, again, compared to the national picture. And it means we are able to offer mutual aid to other health systems around us. In terms of cancer, you can see in the report that we've seen a significant increase in the volume of 2-week wait referrals, particularly in lower GI and breast. 62 days continues to be a challenge for us, particularly around complex pathways and capacity from tertiary providers. As you drew attention to at the beginning of the meeting, we have a corrective action statement in play around 62-day performance, and that will be included in the IPR at the next board meeting, is being led by Robin and Catherine. I won't talk to the mortality number that's referenced in the report. Catherine's already covered that ground. And I won't also draw on the staff health and wellbeing piece, because Gert's obviously just talked to that in the previous item, but those are continued areas of focus for us as an executive team with regard to performance. In terms of finance, you can see that we've undertaken a detailed forecast outturn assessment with an unmitigated deficit of £4.7 million. Mitigation plan that we've got in place focused on controlling agency spend and additional income associated with mutual aid that we're able to offer sees us get back to break even, which is a good place to be, and again a relatively strong performance compared to others. And I think already mentioned the capital work on site. Robin drew attention to this in the estates piece, but really good to see the next phase of the CDC a spade in the ground there, and the buildings being demolished to make way for the construction of that phase 2 building. So those are the highlights. and areas of continued focus where there are performance pressures. Happy to take any questions and draw colleagues in as appropriate.
That's great, thank you. I'll let others go first. Questions and perspectives, Glenn?
As you rightly highlight, I think the ambulance handover times are particularly impressive despite the pressure that we're under. That dashboard showing 0.7% compared to, I think, is it a regional or a national 18% is a really significant indicator for us. This is a question for Robin, but obviously one of the things that then happens is that we attract intelligent conveyancing and ambulances coming from further afield because they can be turned around quickly. What are we doing over the winter to ensure that we can then discharge those patients out into their local discharge to assess or virtual wards or whatever capacity may exist out there? Because that's a particular challenge when they're from out of area.
Yeah, thanks, Glenn. I'm happy to pick that one up. You're right. We see we're a net importer effectively of ambulances from across the rest of the region, particularly the Birmingham area, and also coming in from the Leicestershire area as well. So for the Birmingham areas, we're linking in through the ICB colleagues and the regional links into their social care teams to ensure that we've got robust mechanisms for following up with patients and highlighting patients where we do see delays. What I've also done is met with the lead for Leicestershire County Council and discussed the links through winter with their social care teams. And what they've agreed to do is provide, and which they've started to do already, is provide a member of their team to link in with our teams on a daily basis to ensure that patients that are from Leicestershire are identified quickly in the process and expedited through so that we maintain a good flow in all directions for those out of area patients.
Okay, thank you, Robin. Any other questions or perspectives on the IPR?
Sorry, Russell, could I just come back on another point? I did lower my hand and re-raise it. And it's another Robin. Sorry, Robin, but you're ops, so you get the questions. Mutual aid from an elective perspective. I'm really keen for us to do whatever we can to help colleagues and patients in Leicestershire because their waiting times are a regional, national concern. It would be good to get a bit more of an idea of how that's shaping up. I know there's opportunities around a number of surgical specialists, but I think also there's an opportunity to help them with their cardiology waiting time. So I think that that's something I'd just like us to have a little look at what our plans might be to assist.
Okay, yeah, happy to answer that. I went and met my counterpart, John Melbourne, who's the Chief Operating Officer at UHL a couple of weeks ago, so we could talk through how we can streamline the processes. And part of that will be our Directorate General Manager for Surgery from George Eliot is going over on a 12-month secondment to work with Leicester. And she will be specifically working on their mutual aid patients. So she's very clear on exactly what the capabilities are at George Eliot, the types of patients and where we've offered capacity and support to Leicester, and will help to push that activity from Leicester in an appropriate way to George Eliot so we can maximise their flows. And she starts there at the beginning of January. So we will make sure that is working well so we can get those patients through in a timely manner to support.
Okay, great. Thank you, Glenn. Just a couple of things from me. And this is a sort of Gertie and Hack point to take away. Gertie, on the workforce section, we no longer sort of have an easy way to identify how many FTE we have, particularly compared to FTE in 2019. And Hack, my reason for wanting that is and I've asked Robin, Andy Parker the same issue down in Wye Valley, and I'm going to ask Harkmel the same issue at Swift, is I want to get a measure across the COOs and the finance directors, a common measure of productivity per head compared to 2019. because I think what our integrated performance dashboards are hiding at the moment is actually frontline FTE is significantly up on 2019, but the amount of stuff we're doing is only up a bit. And we've got issues around complexity and acuity, which are driving down the productivity compared to 2019 because it's taking longer to look after more complex patients, and we've got issues of absence and sickness. So I want to get a regular measure in, which are like you, Hack and Robin, and with input from Gertie, but to discuss with other colleagues in the foundation group so that we can talk about productivity per head in a more meaningful way. Because when I look at the challenges the NHS are facing, the issue of productivity per head is a real issue, but it is being affected by complexity of our patients and their acuity. So I want to be able to talk about that narrative. My second point, Robin, sort of relates to partly Glenn's first point and David's introduction. And I do think we need to ensure we are minimising situations where we are shooting ourselves in the foot. And if I can talk about delayed discharges or right to reside or however we want to measure it, but where we have situations where we need to improve our internal processes to get a patient home faster, to free up a bed, we should absolutely make sure we stop shooting ourselves in the foot on that one. And as systems where we relate to social care, that we collectively stop shooting ourselves in the foot, keeping people in an acute setting at £300 a night compared to having them in a community setting where it costs about £30 a night. So this issue of stop shooting ourselves in the foot on some of these issues and minimising those incidents is another theme I'm going to be pushing as we go through winter, because we do need to minimise this self-harm, as I would use it in different worlds, as a turn of phrase. We need to minimise that to maximise our own productivity and efficiency. Are colleagues happy to move on to capital? Sorry, final point. I do think if we end up break even this year, it's a remarkable result. So it's great to hear those mitigation plans in place. So Hack, what would you care to pull out of the capital report, please?
Thank you, Chair. There's a comprehensive paper in the pack that links closely to the estates update we had earlier in the meeting. I'll draw out the key points, but some introductory remarks first. I think one of the things that stands out from the paper is the sheer number of changes we've had to the capital programme this year. So managing the capital programme has been trickier this year than most of the years. So we've got the usual late notification of funding, which we always expect, but that's been exacerbated by slippage on some of our planned schemes. We've also got overspends on some schemes, partly due to specification changes, but also due to inflationary pressures as well. And we've had to defer some of the projects as well for a variety of reasons, which are all detailed in the report. So it's really quite a tricky position to manage. So we will review all the changes that have happened this year to help us to kind of learn and inform planning for next year to try and minimise the changes and make sure we've got a robust plan to start off with. So there's some work to do there, I think. In terms of the three key areas I wanted to pull out, the first one is around the success we've had once again in terms of gaining some significant additional funding over and above our normal operational capital allocation. And the main element you've heard already is due to phase 2 of the CDC. So that's £10 million worth of additional funding split between this year and next financial year. And because there was some regional capital flexibility this year, we've also been able to pull forward the investment in the MRI scanner and the CT scanners. We'll have those delivered earlier in the project than we originally anticipated. And that accounts for most of the increase in this year's capital programme from £10 million to £12.5 million. The second point I was going to raise around the challenges this year that we're going to have in spending a significant sum in the last few months of the year So we've planned ahead and we've already, through Trust Management Board, agreed a list of projects that we could mobilise quickly and pull forward to account for any slippage that we have on this year's programme. That largely relates to equipment we are planning and buying anyway next financial year. So that those are things that are relatively easy and quick to initiate if we need to. And finally, we've been successful in securing additional capital investment over the last few years. And to some extent, that's been down to our future planning and being having shovel-ready bids in place. So you also see within the paper the list of projects that we're actively working up, and we'll continue working those up and be ready to go if any additional funding does become available for anything that we've got in our pipeline. So I'll leave it there and take any questions.
Thank you, Hack. Very clear. Any questions or perspectives to Hack on the capital update? Great news on those additional capital streams coming on board. That's got to be really good news for the citizens that we serve. So well done on everyone involved in making that happen. Colleagues, happy therefore to move on to the governance section of our board report. And the first is the summary of ratified policies. David?
Yes, thanks, Russell. So take the paper as read. It basically sets out as a matter of record the 4 policies that have been approved through the policy review group. So anybody's got any questions, happy to take them.
Thank you. Any questions for David on the summary of ratified policies? Okay, thank you, David. Duly noted. And then we've got the annual schedule of business and calendar of meetings. Sarah?
Thanks, Russell. So the report outlines the schedule of business that the board should expect to see next year, and then also the proposed calendar of meetings for board and its committees for 23-24, both for the board's approval, please.
Thank you. Thank you to you and Ness for putting it together. I know it's not an easy process. Any questions on the schedule of business for next fiscal year? Everyone happy to approve? If you're not happy to approve, please raise the digital hand. I'm having me worried there for a second, Umar, with that thumbs up. So duly approved, thank you. So we move on then to subcommittee chairs update. The first is the Quality Assurance Committee of the 25th of October, and then a verbal update on the 29th of November. What would you like to emphasise, please, Sarah?
Thanks. I think the paper's there for the 25th. I think the verbal for the more recent one, we did spend quite some time looking at the maternity as we've done today, and I think I'd like to comment really that I'm happy that the committee gives a good amount of scrutiny to the papers that are there, that we do receive assurance from executives and honesty where issues are highlighted. And as Catherine has already brought out, we have spent a considerable amount of time looking at the mortality data and gaining assurance from executives regarding when and how we would be expecting to see an improvement in that data.
Okay, very clear. Thank you, Sarah. Any questions or perspectives to Sarah on those 2 updates? Thank you, everyone who's involved in QUAC, for your hard work and all the material that goes on behind the scenes. I know it's a substantive. Similarly, an audit committee for the 29th of November. Julie?
Thanks, Chair. Just very quickly, I'll assume read, just draw attention to the outcome of the internal audit reports for serious incidents, which we talked about earlier as well, and financial sustainability. The latter is going to be shared within the technical group within the system, so that we can actually get a view about best practice around financial sustainability and internal control. We did ask for some further assurance around the processes supporting reporting around governance below boards. And I would just ask the board to note that we are compliant with current COVID-19 inquiry guidance.
Thank you, Julie. Any questions to Julie as Chair of the Audit Committee? Okay, thank you, Julie, and everyone involved in all of the work done for Audit Committee. So, Glenn, on to the Improvement Board, the 15th of November.
Yeah, I'll take the report as read, Chair. Happy to take any questions.
Thank you. Any questions to Glenn on the Improvement Board meeting? Okay, stunned in silence. And we had a good session last week, Glenn, didn't we, at the Foundation Group Subcommittee, where we looked at some of the really good work that's been going on in improvement. So, again, for members of the public who sometimes wonder what are the real benefits that are coming out to us at George Eliot from being a member of the Foundation Group, I think our answer would be very substantial, both in terms of sharing best practice, learning from one another, creating a learning and innovation culture across all three different organisations, and it's good to see that coming through. So we've then got, just for information only, some older subcommittee minutes just for approval. The first is the QUAC from the 27th of September and the 25th of October. Sarah, anything you'd like to add? Okay, thank you. If you're any questions from colleagues? Okay, thank you. And then the Audit Committee of the 28th of July and the 27th of September. Anything you'd like to add, Julie? Any questions to Julie? Okay, any other business for members of the board? Please raise a digital hand. Only one from me, which is to welcome everyone, or to wish everyone a very happy Christmas by the time we get there. It still feels a while away, but I think it's only 3 weeks this Sunday, so make sure you've done all your Christmas shopping. But we are also very conscious of the fact that for many of the citizens we serve, this is going to be a very tough winter and Christmas. So, you know, our hearts go out to everyone who's suffering from the economic challenges, but also to those who are on their own. Maybe this Christmas there are, and we're very committed to supporting at the George Eliot and at Swift as well. There are very many community groups for those of you who are on your own. So I think we're then on to public questions. Sarah, I think we did have some questions from members of the public, didn't we? Did Natalie have a question for us?
Yeah, we've had 2 questions from Natalie Mills and David Carr on behalf of the Patient Forum. So the first one is, following the September change in the stroke pathway and the partnership with UHCW, could you give details of how the stroke pathway is set up between UHCW and George Eliot and what it means for the patients? And Robin's going to answer this question. Thank you.
Thank you, Robin.
Okay, thank you, Chair. Thanks, Sarah. So the stroke pathway changed, we know, a few months ago, beginning of September, and that has made a significant impact on the stroke pathway as we would have known it. So now when patients are seen in George Eliot's ED, if they're suspected as a stroke, there's a conversation that takes place between the clinicians at George Eliot ED and the stroke clinicians at UHCW. And based on scan results, etc., they would be transferred over to UHCW as a hyperacute stroke unit and for their acute stroke care. Once they reach a point where they're in a position for ongoing care and rehab, they then get transferred to either of the 2 rehab units. So for patients coming from North Warwickshire, they would come back to Felix Holt Ward at George Eliot. And that pathway has been running extremely well. There's very close links between the teams on all 3 sites, and they're communicating very effectively, and patients are moving through that pathway very effectively to ensure that the right care is provided by the teams with the best skill sets possible to ensure highest quality of care.
That's super. Thank you, Robin. Great to see partnership working across the system. And Sarah, the second question.
So the winter plan describes the role of same-day emergency care and virtual wards. Could you give the public a sense of what type of patients are looked after in these 2 pathways and how they are supported? Again, Robin's going to answer this question. Thank you.
Thank you. So same-day emergency care and virtual wards were a key element to our winter plans in terms of maintaining good flow of patients through the hospital, but also it's about delivering high quality patient care by patients not spending prolonged periods of time in acute inpatient beds. So if I take same-day emergency care as the first point, that service picks patients up as they arrive in ED, they're seen by ED, and where they need further medical input, they can then, under set criteria and discussion with the teams, they then get transferred to the same-day emergency care unit, and they get treated outside of the ED environment, which is a much calmer environment and conducive to the care that those patients need. And just to give an example of the numbers we're talking about, back in June, the numbers going through that was very, very small and almost in single figures, as that area was supporting our surge capacity on the site. Since June, we changed that and took decisive action to stop using that as a surge capacity area. And we heard this morning as a board that those numbers have now risen to 554 patients in November that were seen through that channel. And so that's a huge number and a real benefit to those patients who've been able to go through that process and that service. And the next steps for that are to start taking patients directly from ambulances, so patients don't need to go to ED at all. They already take patients who are directly referred in from GPs into that service, and also looking at patients who potentially in ED could well need admission, but with that extra care and support from the medical teams in SDEP unit, then they can get turned around and they can go home. So that's the SDEP unit is it's really developed over the course of the last few months. The virtual wards, we're now up to a capacity of 25 patients on virtual wards. We've got actually 20 patients at this point, so we increased from 20 to 25 in terms of capacity on the 1st of December. The teams are working really hard with the ward teams, looking at patients with predominantly cardiology, respiratory issues, although they are looking at other general medical patients and also patients who require longer term IV antibiotics. And those are all managed in the community now under the care of our consultants and our clinical teams, but in their own homes. And that again has been a real increase in numbers that we've seen through that service as a real benefit to those patients who can now stay at home or be discharged earlier from the inpatient wards. And we monitor the length of stay of every patient on that virtual ward in line with their length of stay in the hospital, and then in addition the time they spend on the virtual ward. So we're not extending the overall length of stay. All we're doing is getting those patients out home so they can be in the comfort of their own home and with their loved ones.
Very helpful, very comprehensive. Thank you, Robin. We've just got a couple of minutes if any members of the public want to ask any more questions. David Alderman. David, if you're talking, I can't hear you.
Okay, sorry, that's a pound in the charity box, Chair, for not coming off mute in time. From the catchment area residents, the staff at the George Eliot Hospital, from the painters to the porters to clinicians, we'd just like to put on record, Chair, an enormous thank you for the service provided during 2022. Thank you, Chair. I did have a question. I don't know if Sarah is going to mention my question as well.
Well, just to make sure, David, that's very kind of you to say what you've just said, but I'll ask away with your question.
Well, I understand that quite recently, I read this on social media platforms. I'm really with it, you see, that the George Eliot held a new model of recruitment day, and I understand that we might be. How was that day? And I understand that you might be repeating that that particular program. Can you give me some detail, please? Thank you.
Of course, David. Obviously, you're more ahead of than I am on this social media malarkey. I was criticised in the workshop this morning for being out of date and not knowing what a vlog was. But Gertie, would you care to brief David on our plans regarding that type of issue?
Yeah, absolutely, Chair. I'm really pleased to share with the board and with the public. Obviously, recruitment is a huge focus for us, and attracting staff in a key priority area for us. We took a decision to really speed up and streamline our recruitment process. Two of the areas we have particular pressures around are our ward hosts and our domestics. And as Simone's already highlighted, new non-clinical roles, but really important to the delivery of safe, effective patient care. We did a rapid recruitment process on the 26th of November, so a complete one-day fill in your registration form, give us your details. We offered 28 posts in total. We had hoped that actually some of those colleagues will be starting this week, a week later. Most of them will actually be starting next Monday, and that's reflecting their preference rather than any delays in the recruitment process. And I'm really pleased to share with colleagues that we have 11.5 whole-time equivalent domestics starting with us next week, and 5.7 ward hosts, and that's 26 people working different hours. Which is really positive. The vacancy has obviously therefore significantly dropped in our domestics, and Kirsty and the team will be reviewing the current risk score for that on our risk register. We have a healthcare support worker recruitment one-stop event on the 12th of December, which Natalie has already mentioned. We plan for further domestic and ward host recruitment in January, and we have the registered nurse approach also in January. So some really fantastic work by, and I would just particularly commend Sarah McLeod, the operational director, and Suki and the recruitment team for all of their really hard work in this. Lots of lessons learned, and we will improve the process as we go through, Chair, but a really positive start for the winter, having all of those additional roles in to support our staff. Thank you.
It sounds as though you have a good model of working.
Absolutely, David. And David, you threw me. You're showing up as David Alderman on my screen rather than.
That's for the sake of David Eldringham, who saw me as some other name in the past. David something. Thank you, Chair. Merry Christmas, everyone.
Okay, and Merry Christmas indeed to you, and look forward to seeing you. We do have a Foundation Group 3 boards meeting in February. The details of that will be made available, but the next meeting of the George Eliot board will be on the 7th of March. So Merry Christmas, everyone. Look forward to seeing you soon. To my board colleagues, and I suggest we have a quick 5-minute comfort break and then get into the confidential board so I can save you some time. Thank you very much, everyone. Take care.